Assalamualaikum and good afternoon to all doctors, ladies and gentlemen. Welcome to training on Clinical Practice Guideline for Primary Care Providers, CPG Management of Asthma in Adults, second edition. This training is a collaboration by Malaysia Health Technology Assessment Section MATAS from Medical Development Division, Ministry of Health Malaysia, Malaysian Medical Association, MMA, Academy of Medicine of Malaysia, AMM, and Academy of Family Physicians of Malaysia, AFPM. The objective of this training is to actively disseminate content of the evidence-based CPGs to the primary care providers and thus increase its utilization. We also hope that this training will improve the quality of healthcare provided by the private GPs and also primary care providers based on the best and up-to-date clinical practice. We would like to convey our appreciation to all participants for registering for our training today. For those who are unable to join our webinar via Zoom, you may also view our webinar through MMA FB Live. Thank you very much for your support. First and foremost, I would like to invite Yang Berusaha Dr. Tuan Zamani Ahmed Tuan Zakaria, representative from Private Practitioner Section, Malaysian Medical Association, to give a few words. Please welcome Yang Berusaha Dr. Tuan Zamani.
Assalamualaikum and good afternoon, everyone. I'm Dr. Zamani from Honorary Secretary of PPS Malaysia, private practitioner section of the MMA, Malaysian Medical Association. So on behalf of PPS MMA, I would like to warmly welcome everyone to today's training of clinical practice guideline for the management of asthma in adult second edition. So this program reflects the strong collaboration between PPS, MMA, MATAS and Ministry of Health Malaysia, working together to ensure the evidence-based practice guidelines are effectively implemented and explained to our primary care. And today we are honored to have excellent panel of speakers, Dr. Maza Pusvavina Muhammad Yassin, Dr. Nur Azila Muhammad Isa, Dr. Nida Ulhuda Aznan, and Ms. Chong Li Yin. Thank you. And of course, with Associate Professor Dr. Andrea Banyudin as our moderator. And again, we would like to acknowledge the valuable contribution of Dr. Karen Sharmini Sandanasamy from MATAS and her team. And we hope this session will be beneficial and enhance our practice in managing asthma patients. Thank you.
Thank you very much, Yang Berusaha Dr. Tuan Zamani. Next, I would like to invite Yang Berusaha Dr. Karen Sharmini Sandanasamy, Head of CPG Unit from MATAS, to give an overview of the training today. Please welcome Yang Berusaha Dr. Karen.
Hi, everybody. Thank you for joining this training. First and foremost, I would like to take this opportunity to thank MMA for providing this platform for this GP practice. For today's session, you will be having a discussion on the CPG management of bronchial asthma in adults. These lectures will include discussions on risk factors, on management of stable asthma at your primary care. And it also will help you to identify exacerbations of asthma and how to actually refer your cases to tertiary care. At the end of the sessions, we will include a case-based discussion where you will be hands-on discussing on the management of asthma at the primary care level. I would like to also take this opportunity to thank our honorable speakers who have taken their time and their weekend off to actually be here with you guys. So I hope you would take this opportunity to benefit out of this training and hopefully actively disseminate the recommendations of the CPG into your practice, so that we can manage asthma better at primary care level. Thank you.
Thank you very much, Yang Berusaha Dr. Karen. Before we start with lectures and the case discussion, I would like to invite Yang Berusaha, Associate Professor Dr. Andra Ban Yulin, Consultant Pulmonologist from Hospital Chancellor Tunku Muhriz, University Kebangsaan Malaysia, Kuala Lumpur, to moderate the next events. So let's get to know her. She is a Senior Consultant Physician and Pulmonologist in Hospital Tunku Muhriz, University Kebangsaan Malaysia, specializing in asthma and chronic obstructive pulmonary disease, COPD. She is the current head of the respiratory unit in the Department of Medicine. She has conducted research particularly in asthma, COPD, and tuberculosis. She has published and presented in national and international congresses. And currently, she is also a member of Malaysian Thoracic Society, MTS, and Malaysia Association for Bronchology and Interventional Pulmonology, MABIP. Without further ado, please welcome Yang Berusaha Associate Professor Dr. Andrea.
Thank you very much. Right, thank you very much. The technical thing was just to make sure that everyone is awake. Right, so we have, I think as mentioned, we have 5 speakers, including myself, and the 4 are actually friends of, we are all friends with each other. So I think this is a good platform for you to actually send in some decent questions for us. Be kind to us. It is a Saturday, right? So I'd like to start off by introducing the first speaker, who is Dr. Maza Puspavina, who is actually a friend of ours and also a member of the CPG, Asthma CPG. She's a consultant family medicine specialist from the Faculty of Medicine, UiTM. And she will deliver the first lecture for this afternoon. And the title of her lecture is Asthma Basics, Risk Factors and Diagnosis in Primary Care. With that, I'd like to invite Dr. Maza to share her slides and start her talk.
Okay, Assalamualaikum. Good afternoon, everyone. I'm Maza. Okay, bear with me. I'm going to share my slides. Okay. Can you all see my slides? All right. Okay, Bismillahirrahmanirrahim. Assalamualaikum again. Okay, so I am Maza from UiTM Sungai Buloh. So for the first topic today is I'm going to cover about asthma basics, risk factors, and diagnosis in primary care. Okay, so this is the learning objectives. Number 1, definition of asthma and definition of severe asthma. And we're also going to cover about risk factor. So there are a few risk factor here. Risk factor of developing asthma, risk factor for future exacerbation, which you need to recognize, and the risk factor for severe asthma, because you want to prevent life-threatening conditions. And thirdly is the diagnosis of asthma. Okay, first definition. What is asthma? So asthma is a heterogeneous disease with distinct inflammatory patterns. So we all know from our undergraduate medical school and your postgraduate education is inflammation basically. It's divided generally into 2. Number 1 is the type 2, where you have a high T2 is driven by the T2 cytokines. So this type of asthma is actually cause more inflammation, elevated in IgE levels, and increase in FeNO levels. I will tell you about FeNO later in later slides. And this type of asthma is actually responsive to our inhaled corticosteroids and biologics. Okay, we're not covering biologics here because we are training for primary care providers. Okay, and the next group is the neutrophilic asthma, where this is associated with low or absent T2 inflammation. So this relate to the low or absent T2 biomarkers, normal FeNO levels, and usually is steroid resistance often observed.
Here I show you a big picture, a big glance of asthma severity from stable to severe. So what do you mean by stable? Stable asthma, when patients have well-controlled symptoms, use PRN or as necessary of reliever. There is no activity limitation. Patient can go exercise, swimming, okay? Normal lung function test, okay? Then we have under the stable asthma, where you can have mild to moderate partially controlled, or you can have uncontrolled asthma. So the partly controlled or partially controlled, you have the mild asthma where the symptoms or the patient needs to use reliever more than 2 times per week and low dose of inhaled corticosteroids. So low dose means your budesonide dose around 100 to less than 400 mics per day, okay? And then you have the moderate asthma where the symptoms increase as a daily symptoms. And then the some of night waking symptoms. And this patient needs higher dose of steroids or ICS LABA. Then you have the uncontrolled asthma, whereby this uncontrolled asthma, you have poor symptom control. If you remember the physician questions, 4 physician questions about asthma control, whereby 1 is a daytime symptoms, number 2, use of reliever 2 times per week, number 3, activity limitation, and number 4, night waking symptoms. So if patient has 3 out of 4 that I have mentioned above, shows that patient has poor symptom control, or the patient has frequent exacerbation, more than 2 times per year using the oral corticosteroid, because you know that when patient come from acute exacerbation, they will need a oral prednisolone for short term, okay? Then, or more than 1 time per year of hospitalization. Usually, this kind of patient of uncontrolled asthma, they affect by the, most commonly due to the modifiable risk factor shown below, whereby patient can have incorrect technique. So you need to check the patient technique again and again every time patient comes for follow-up, okay? Poor adherence, that is a very common, 80% patients say they adhere, guna doctor, guna, but actually patient might be poor adherence, which Miss Lee Ann will talk to you about this later, okay? And then smoking, okay? Sometimes the second-hand smoke or the environment can be the triggers, okay? Comorbidities, as you know, in Malaysia nowadays, the issues with obesity, okay? There are 50% of overweight and obese in Malaysia. So 1 in 2, okay, is obese, okay? And then if it's misdiagnosed, which is quite rarely actually. We talk about diagnosis later. So the next one is difficult to treat asthma. What is difficult to treat? Despite the high or medium dose of ICS, plus a second controller of long-acting bronchodilator. Usually if patient in step 1 or 2 or a low dose, we use the short-acting bronchodilator. But in patient difficult to treat asthma, they need a long-acting bronchodilator and often influenced by the modifier factors. So this patient is considered under difficult to treat. If patient already maximum the optimization the medication and control the modifiable factors, meaning that the technique is correct, adhere, and already control the triggers, and patients still have symptoms, then we have severe asthma, which is a subset to the difficult to treat. So patient can have uncontrolled symptoms despite maximal optimization of the treatment, whereby we already exclude the modifiable risk factor. So what are the risk factors for developing asthma? So first component is the host or genetic. Okay, number 1 is female. Why female? Female because we have a lot of abundance of sex hormone, estrogen, progesterone, which can affect our immune response and inflammatory pathway. And estrogen also actually link or enhance the interleukin, which can also increase the eosinophilic activity. And our progesterone increase the airway hyperresponsiveness, so modulates the beta receptor function, okay? Another way, because female size is are smaller than male, so their lung volume is smaller. So because of smaller airways, so because of that, the risk factor is higher. Another thing, being female, neuropsychological stress factor level higher, there will be higher level of anxiety. Okay, then we go for the next is atopy. So as you know that atopy, allergy rhinitis have higher risk of developing asthma, bronchial hyperresponsiveness, okay? And then if patient has a parental asthma, one of your parent has asthma, so that's why the genetic link is strong. So you always have ask whether in the family history, they have family history of asthma. So this is a basic knowledge lah, okay? And then for the environmental, exposure to allergen, like the house dust mites, pollen, cockroaches, okay, and then tobacco smoke, okay. So if the environment is not clean, so you can have like 4 times more likely to develop asthma. Same thing with the air pollution. Okay, so what are the irritants? Some patients have to deal with the occupational irritants. So those involved in nitrogen dioxide, carbon monoxide. So in some factories, sulfur dioxide, and also some particulate matter. Okay, so these are caused by the environment risk factor. Next is the perinatal or childhood. So younger maternal age have a higher risk of developing asthma. Okay, and then maternal with preeclampsia so also have high risk of developing asthma later. Okay, maternal who smokes, especially during the pregnancy, they smoke. Okay, and then those who born, if a baby born via Caesar, okay, so you know if a normal delivery with the lung expansion, you have a better APGAR score. So not those with the Caesar, okay. History of not receiving breast milk, okay, and then the lower pulmonary function of neonates, okay. Then I go next into the socioeconomic. Socioeconomic is another factor because of a limited access to education or healthcare. So patients tend to not to take care of their health, okay. And the last that I want to touch on and very important that you need to consider when you're seeing asthma patient is the comorbidities. Again, I have to emphasize on the obesity. So obesity is a risk factor for developing asthma. And then as we understood, allergy rhinitis, chronic rhinosinusitis, or GERD. All right, okay. So for the, come again for the allergy rhinitis, actually 40% patient with allergy rhinitis can have asthma. Okay. So this just now is the risk factor for developing asthma, and this one is the risk factor for future asthma exacerbation. So number 1 is the history of medication use. So if the patient has previous history of severe asthma exacerbation, which require systemic steroid, so either oral or IV hydrocortisone, or patient need to be admitted within the past year, so that is a risk factor for future asthma exacerbation. So you need to ask this question when you're dealing with asthma, either come for follow-up or want to continue medication. Okay, you have to explore this history. Okay, number 2, the overuse of SABA. You know, your salbutamol inhaler, the maximum in one canister, usually maximum either 100 or 200 doses. So if the patient have to use more than 3 canister per year, you can imagine about 600 doses per year that use. So meaning that kalau 1 tahun 300 over days, about 1.5 to 2 puff per day. So that's why it called overuse of SABA. So you need to ask that. Okay, sometimes patient cannot remember or don't want to tell exactly. You just ask, so how many canister you have used last year, for example. Okay, you have bought last year. And then the other one is inadequate ICS use or not on ICS, or poor adherence to the maintenance therapy. This is a very common condition. Okay, patient can bring the pump here and there, okay, but actually patient not using it because when they use it, they cannot feel anything. So they think that the pump is not useful, okay? But they need to ensure, or we must tell them and emphasize that this pump is for prophylaxis. Cegah you daripada dapat asma. So if you not use it, later you pakai all your blue pump, it doesn't work anymore, okay? And then you can have a future exacerbation. Next is the patient factors and technique, okay? Incorrect inhaler technique is very common, especially with the metered dose inhaler. We have an upcoming or already in the pipeline, the newer version, which is easy to inhale. Miss Lee Ann will tell you after this, okay? But if, because MDI is quite cheap and easily available, patient can buy over the counter. So this is a very common thing at the primary care. So you have to assess the patient inhaler technique. Okay. And also Miss Lee Ann will tell you that there's a video in the YouTube online that patient can, you can share with patient and patient have a look at that. Okay. The other one is the current smoker or e-cigarette or vape use. This e-cigarette and vape use is very rampant now, and with the unknown ingredient in the e-cigarette and vape user can really triggers a bad asthma or severe asthma because of an unknown triggers. I repeat again about the comorbidities. So those with obesity, GERD, chronic rhinosinusitis, and then especially those with confirmed food allergy, they have a risk factor for future asthma exacerbation. So food allergy, please confirm the what type of the allergy, meaning that how bad, how severe is the allergy. So if this anaphylaxis, this is a very bad, okay, but sometimes patients just have maculopapular rash with food allergy, just to ensure that there's no mucosal involvement. Okay, either from the, look at the uvula, lip swelling, and all those, okay? So it's very important to determine the food allergy, okay? Pregnancy, previously we used to learn the 1/3 rule. If you are pregnant, 1/3 you can be, as usual, asthma, 1/3 can be better asthma control, the other 1/3 can be worse asthma control. So pregnancy is another risk factor. And those with the high T2 or the T2 inflammatory markers, which has high FeNO and high blood eosinophil, is higher risk factor. Okay, and then lung function. To start off with, if patient did a spirometry, those at baseline, low FEV, especially less than 60%, okay, predicted, and also those with high bronchodilator responsiveness. Okay, so that is the risk factor for future asthma exacerbation. So how to diagnose asthma? We know asthma is a clinical history and symptoms. So a thorough history taking to identify asthma is crucial for accurate diagnosis. Okay, so when you do the physical examination, patient might appear normal because there's variable of symptoms. So especially between exacerbation. So it is important to rule out other condition if you have in doubt. Okay, but typical signs of symptoms, as we understood lah, tachypnea, bronchi, okay, a prolonged expiratory phase, okay, and decreased breath sounds. Be careful with decreased breath sound because some of us might think is a normal breath sound, but actually patient has decreased or even silent breath sound. So at that time, you can consider patient might have an severe or exacerbation, which you need to consider. So actually, there's no gold standard of diagnosing asthma, but spirometry, if available, is the objective measure to diagnose asthma. So with your typical history and physical examination, which consistent with asthma, so can send patient to perform spirometry, okay, with bronchodilator reversibility test, okay, meaning that perform a spirometry at baseline, if can order, then ask patient to take the bronchodilator, then repeat again the spirometry. So if the FEV1, what is the forced expiratory volume at 1 second and over the full vital capacity, which is less than 0.7 or less than lower limit normal, So patient is diagnosed as asthma. Okay. If it's not, then you consider further history investigation and alternative diagnosis. So these are the usual clinical feature for asthma: wheeze, cough, chest tightness, shortness of breath, okay? And symptom variability is very important. So it can be episodic. That's why it's based on the triggers. And then diurnal, usually late night or early morning. And then if patient exercise, okay? So the common triggers, again, infection, common cold, allergen, cold weather, irritants, smoke, haze, yeah, okay. History of atopy, allergy, rhinitis, and eczema, and then family history of atopy. So physical examination, don't forget to check the patient anthropometry. Patient obese, BMI more than 27.5. Check the patient vital sign to make sure that patient should be normal. If it's uncontrolled, we'll show some signs, versus you need to recognize the acute exacerbation. Okay, then you auscultate lah. Okay, so investigation for asthma, as I mentioned, the spirometry. First, to demonstrate the airway obstruction. Number 2 is to demonstrate the obstruction variability or reversibility. So if you do spirometry, you will check the reversibility by giving the bronchodilator. Any improvement of FVC or FEV more than 12%, more than 200 mils, so is a positive test. Okay, for the peak flow, we check can be two things. One is from the bronchodilator or from the diurnal variation. Prof. Andrea will explain to you about the diurnal variation or the peak flow later. Okay, so I skip that. The broncho provocation, you can forget about that. They're not covered in the primary care. Then number 3, if you have the availability of test, a blood test for the detection of T2 high inflammation, so check for the blood eosinophil. So if it's more than 4%, your differential count, check on that. So that is a high T2. And there is a test for IgE, serum IgE. You can send that. If some of you can send to the private lab. Okay, and then the third one is the FeNO. This is an example of a spirometry graph. Okay, so normal spirometry FEV1 should be more or equal of 80% predicted, and normal FVC should be more than 80% or equal predicted. And the normal ratio of FEV1 over FVC should be more than equal of 0.7. If you look at the blue line, is a normal, where here we have sharp rise of a graph and then a nice loop. As compared if patient is obstructive, so there is a lower of liter per second if the patient has obstructive asthma. So that's an example. Okay, this is another example. Okay, so I'll skip this just to make sure that you remember what are the cutoff point. So for spirometry, any airway obstruction variability or reversibility, the FEV1 over FVC more than 12% and more than 200 mils following bronchodilator treatment. So results can be highly suggestive of asthma. So when to do spirometry? So before treatment, meaning that you need to test the patient, and then during follow-up at 3 to 6 months interval, and sometimes periodically when patient maybe stepping up or uncontrolled, that you need to reconfirm again. Okay. So a low FEV1 indicates underlying untreated airway inflammation and is a risk factor for future exacerbation. Okay, so this is the example of peak flow. Okay. All right. So for the peak flow, I'll skip. Prof. Andrea will explain on this. Okay. And this is the blood test. The eosinophil, I repeat again, either more than 150 cells per microliter or more than 4%. And the IgE more than 100 kilounit per liter. Okay. So take home message. Asthma is a clinical diagnosis supported by history of variable symptoms and objective evidence of variable airflow limitation. So spirometry with bronchodilator reversibility is the preferred test, okay, to confirm the diagnosis. But normal results do not exclude asthma. So if you're unsure, can always refer. Okay, with that, I thank you.
Okay, thank you very much, Maza, for bringing us through the basics. Boring but essential. Risk factors important. Diagnosis also very important. I noticed that you said that I will cover some of yours. I hope you live up to it. Okay, so I think we are keeping to time. Thank you, Maza. And I do realize that it's a Saturday. So we'll move on to our next speaker, Dr. Noor Azila Muhammad Isa. She's a consultant family medicine specialist in Klinik Kesihatan Putrajaya Precinct 9. She's currently also attending another course and being a trainer in another course, and she's given up this small little slot to give her talk. And she will bring us through stable asthma management. So even though it's stable, it's important to know what to do during that time, right? So she's going to talk about beyond the SABA only treatment. So with that, I would like to invite Dr. Noor Azila to share her slides. Azila, I see. Can you move forward? You're a bit dark. Forward a bit. Thank you. Okay.
Thank you, Prof, for the kind introduction. Okay, let me share my slides first. Everyone can see, yeah?
Yes, we can.
All right, okay. So thank you, Dr. Maza. I also would like to take this opportunity to thank Matas and also MMA for organizing this wonderful session on a Saturday evening. So I think we have all heard about the diagnosis and also risk factors for asthma. So we will move on with the next topic, which is how to treat stable asthma in primary care. And what we would like to emphasize is basically we want our asthmatic patients to be treated beyond SABA only. Okay. All right, so treatment of stable asthma. Okay, sorry. We have 3 learning objectives for this topic. So the first one is on pharmacological treatment in stable asthma, whereby we would like to emphasize ICS containing therapy is mandatory for all of our asthma patients. And the second one is actually initiating treatment in asthma. So we have heard about how to diagnose asthma patients just now, objectively, preferably by spirometry. And then now we would like to know how to go about initiating the treatment, which medications to choose, and then subsequently to discuss on the stepping up and stepping down of treatment in our asthmatic follow-up. Okay, treatment of stable asthma, of course, also involves non-pharmacological, and it is very, very important for us also to look at this area. In a patient with asthma who smokes, definitely smoking cessation is very, very important. Physical activity and exercise, weight reduction in obese patients definitely plays a role in our obese patients with asthma. And allergen avoidance should be the basic things that we should actually advise our asthmatic patients, pulmonary rehab, vaccine, and of course, we also need to look into the medications which should be used in caution in asthmatic patients. But in view of time, for today's session, we will discuss more on pharmacological treatment. So pharmacological treatment of asthma divided into 2, that is reliever therapy, which is taken as needed for quick relief of asthma symptoms, whereas maintenance therapy targets at asthma symptom control and prevent exacerbation. It is used on a regular basis, even when asthma symptoms are absent. I think this need to be emphasized again and again to our patients in terms of the need for regular treatment when a patient was started on maintenance. So we start with our reliever therapy. We have 2 types. That is, the first one, it has been with us for so long already, which is short-acting beta-2 agonist, SABA. And the second one is what we call anti-inflammatory reliever, or AIR, which can either be ICS formoterol and inhaled corticosteroids, SABA. But I think in our country at the moment, we do not have this ICS Sabah readily as compared to other reliever. So Sabah, inhaled Sabah should not be used as monotherapy. I think Dr. Maza has elaborated the use of, it has been found, big studies have shown that the use of 3 or more canisters of Sabah per year is associated with increased risk of asthma exacerbations and even mortality. Inhaled Sabah can be used as reliever in patients who are on regular ICS therapy. And again, we would like to emphasize oral Sabah is not recommended due to its higher risk of systemic side effects. Now we move on to anti-inflammatory reliever. Anti-inflammatory reliever combines low-dose ICS with a fast-acting bronchodilator, in particular formoterol. Because formoterol is, although it's LABA, but it has the bronchodilating effect is fast-acting. This approach lowers the risk of asthma exacerbations compared when using Sabah alone. And the option actually to either use Sabah or ICS LABA will depend on drug availability, its cost, inhaler techniques, and patient adherence and preference. We would like to remind everyone that only ICS formoterol can be used as anti-inflammatory reliever. For example, we also have another ICS LABA, which is ICS salmeterol. But salmeterol cannot be used as reliever because it has slower onset of action. So just to emphasize, in our CPG, this is all under recommendation 5. So in the treatment of asthma, inhaled Sabah should not be used alone as monotherapy. It can be used as a reliever with regular inhaled corticosteroids and ICS LABA. Inhaled Sabah overuse, 3 or more canisters per year should be avoided. As Dr. Maza said, we can easily ask our patients how many canisters of Sabah that they used last year. And throughout my experience, I'm sure everyone agrees, there are some patients who have 2 or 3 Sabah with them, whereby one they buy in this pharmacy, and the other one they get from one KKA, and the other one they get from KKB. So we really have to be careful with these patients. And oral Sabah should not be used. Anti-inflammatory reliever air therapy may be used as reliever therapy. And I also would like to emphasize, inhale LABA alone without ICS should not be used as reliever monotherapy. For example, if we have LABA in the form of formoterol, without ICS, it cannot be used as a reliever. And we move on to maintenance therapy. We have many options as in terms of our patients, in terms of our treatment. So the first and the most common that we have been using is inhaled corticosteroids, ICS LABA combination, given in the form of maintenance and reliever therapy, leukotriene receptor antagonists, for example, montelukast, methylxanthine. I think it has been theophylline is one of its medication under methylxanthine. But now we have other medications under methylxanthine called doxorubicin. We also have LAMA, long-acting anti-muscarinic, macrolides, oral corticosteroids, and sublingual immunotherapy. In view of time, we will only discuss about the first three maintenance therapy because all the other basically like macrolides, oral corticosteroids, SLITs are basically given at the tertiary center. So inhaled corticosteroids, it has been shown significantly that it is significantly reduced asthma symptoms, risk of exacerbation, hospitalization, and death. And studies have also shown if you switch one ICS with another within a category, there could be a difference in terms of asthma control, and because different ICS may vary in potency. We need to know that ICS dosage actually are categorized in terms of low dose, medium dose, and high dose. And this is important because high dose ICS can actually have potential side effects if being used long term. That is osteoporosis, cataracts and glaucoma, and even adrenal suppression. So this table actually illustrates to us the difference between the dosage of the dosage of the inhaled corticosteroids, where they are divided into low dose, medium dose, and high dose. And different ICS can have different level. For example, if we can see that in beclomethasone, PMDI, low dose is 200 to 500 microgram, medium is 500 to 1000, and high is more than 1000. But if we look at fluticasone, the low dose is even lower, 100 to 250, 250 to 500 is medium, and more than 500 is high. So when we prescribe our patients, we can actually calculate and estimate or assess whether the patient is under low or medium or high dose of ICS. So let's look at this example. For example, we are giving the patient salmeterol fluticasone, which is seretide, 25 stroke 125 microgram of fluticasone, 1 puff BD. So remember, seretide, we can only give 1 puff BD and not 2 puff BD. The maximum dose is 1 puff BD because of its salmeterol component. So the total dosage for its fluticasone is 125 times 1 times 2, that is 250, which fall into low dose. Yeah. So if we need to switch this patient to medium dose of salmeterol fluticasone, we need to give the patient with 25 to 150. Yeah. And similarly with budesonide, so we have to look at the budesonide component, which is 1 puff is 160 microgram. So 160 microgram times 2 puff, and if given 2 puff BD, and that sum up to 640 microgram, which fall into medium dose ICS. So that is for the ICS. So we move on to ICS-LABA combination. So these asthma patients who remain symptomatic despite good adherence and inhaler technique to regular daily low-dose ICS or as needed ICS formoterol can be step up to ICS-LABA combination. And studies have shown that combination of ICS-LABA is preferred to high-dose ICS during stepping up of treatment. And it is more effective in reducing exacerbation than high-dose ICS alone. And as we all know, high-dose ICS is also high risk of potential side effect. And what is SMART therapy? It is actually daily use of ICS formoterol inhaler for asthma maintenance, and we also use the same ICS formoterol for symptom relief. Studies have shown in mild to moderate asthma, low-dose SMART has been found to be better than ICS-LABA with as needed SABA and ICS with as needed SABA. In moderate to severe asthma, either low to medium dose SMART or high dose ICS-LABA plus as needed SABA can be used at its same potency. I would like to also remind us all is to check on patient. If this patient, we have actually discussed with the patient and they agreed to use SMART, please remind them, please emphasize to them, they cannot use Sabah as their reliever, because I have seen a few patients where we give MAR therapy, but they also use Sabah in between as their reliever, because that will actually contradicts and probably can actually worsen the condition. Yeah. So okay, let's talk about other treatment. LTRA, Montelukast, can be added to ICS containing therapy in patients with concomitant allergic rhinitis. LAMA, long-acting muscarinic agent, may be added in patients who remain symptomatic or have exacerbation despite the medium or high dose ICS LABA. Theophylline, the methylxanthine group, was used to be popular. I remember doing study in the district that I worked before. Theophylline was second to ICS for maintenance therapy, but it actually a lot of studies have shown that it should not be used for treatment of asthma due to its limited clinical benefits and high risk of side effects. There are new methylxanthine coming in, but the benefits is not strong yet. So oral corticosteroids is not recommended for routine long-term asthma control in primary care. So these are the recommendations, same as what I've mentioned before. So let's move on to this diagram in terms of which can actually help us to decide which medications that we want to give to our patients. So we will go step by step. So the moment we confirmed asthma as what has been described by Dr. Maza before this, we need to assess the patient's asthma control. As compared to diabetic patients whose assessment is through HbA1c, hypertensive patient by the blood pressure monitoring. So for asthma, we do not have any objective physical examination or investigation that we can do, but we have validated tools that we can use to determine whether what is the control of asthma of the patient. Okay, so this is GINA assessment of asthma control, where we ask 4 main questions. So if the patient do not have any of these symptoms, for example, daytime asthma symptoms more than twice per week, any night awakening, SABA reliever for symptoms more than twice per week, or any activity limitation due to asthma. If the patient said, no, I don't have any of these, so that means the patient have well-controlled asthma. If the patient said yes in 1 or 2 stems, then the patient has partly controlled asthma. And if the patient complained of 3 or 4 or all, that means that the patient's asthma is uncontrolled. So the other tool that we can use, which is self-administered, is asthma control test. The questions are a little bit about the same with the GINA assessment table just now, but it is more, it is graded into 5 categories. Yeah. So from my experience, the first time that you want to introduce the patient to use to answer, you might need to help the patient a bit, explain. But subsequently, when patient is confident, then they are able to answer themselves. Yeah. So the scoring. So if the patient, so of course we will just follow the numbers here. So if the patient score as a whole 5 to 15, that shows that the patient have very poorly asthma control. 16 to 19 not well controlled, and 20 to 25 well controlled. Okay, so after we have confirmed, we have assessed the asthma control, we also have to look at whether this patient have high risk of future exacerbations or not. Yeah, including poor adherence or incorrect inhaler technique, but we are talking about patients who are newly diagnosed. Yeah, so I think this one Dr. Maza have covered very well in her first lecture. So these are the things that we need to also know in our patients. If the patient have previous severe asthma, requiring ICU admission, for example, of course, we have to make sure that this patient need to be treated aggressively. And similarly, if patient is smoker, pregnant, or have low lung function, we know that this patient really needs treatment, and we will and follow up. Okay. So, let's say we have assessed the risk factor, assessed the asthma control, and from our assessment that the patient asthma control is well, so we can either start the patient on maintenance low dose ICS and PRN SABA. Last time we used to have only PRN SABA, but now if you can see, none of the choices have only SABA or reliever alone. So maintenance low dose ICS or PRN SABA, or PRN ICS formoterol, or PRN ICS SABA. How to choose is basically depending on patient. I have patients who actually do not want to take medications regularly. So probably PRN ICS formoterol would be a better choice. But some patients who think that no, they want something regular and they are compliant with it, probably maintenance low dose ICS and PRN SABA can be given to this patient. So if patient do not have well controlled asthma, so we can look at two options. Whether the daily symptoms was most days whether was the symptoms was most days or daily symptoms. And night awakening, FEV1 less than 80 basically fall into these categories. So let's say if the patient have symptoms most days, we can start the patient straight away with maintenance low dose ICS LABA or low to medium dose ICS. If the patient has daily symptoms or night awakening and FEV1 less than 80, we can consider that the patient on a higher treatment, that is maintenance medium to high dose ICS LABA or medium dose ICS LABA with added LAMA. So after starting this treatment, patient need to be reassessed 3 to 6 months, and then subsequently, if the patient's asthma control is well controlled, then we continue the current therapy and we decide to de-escalate the treatment when we think that the patient is ready. Normally not too soon, probably after 3 to 6 months, depending on their risk factors for future exacerbation. And if it is not normal, so we have to escalate the treatment. During every time when the patient, when we review the patient, we always need to check whether the patient was compliant to treatment or whether the patient is using the inhaler technique correctly. Because these two common issues is always happening to our patient. So no point of us escalating, but actually the technique is very, very poor. So remember, no more SABA monotherapy, all should be on ICS containing therapy. If you want to give reliever therapy only, then ICS formoterol would be the answer. So this is the step up and down table in the CPG. So for example, if you start a patient on low dose ICS LABA or medium dose ICS, as a starting, and then when you review the patient after 3 months, after checking the inhaler technique and also compliance to treatment, patient comply, patient take the inhaler technique correctly, then you have to step up to medium dose ICS LABA. And then subsequently, after you have reviewed the patient, again check similar things, also look for comorbidities and have treated them all. Then if the patient is not better, then you have to consider stepping up. Either we give high dose ICS LABA or medium dose ICS LABA plus LAMA. But by this time, we should be doing phenotypic assessment already. What we mean is probably we would like to know what is the eosinophil level. If you have IgE, blood, you can actually do that, and then subsequently, if the patient's still not better, we have to consider referring to the tertiary center, probably respiratory clinic, so that patient can be assessed furthermore, and to decide for higher level of medications. Yeah. And then subsequently, if the patient on high dose ICS LABA, for example, and you have noticed that the patient has been well controlled with risk of future exacerbation has been controlled and lowered, you can actually consider reducing down to medium dose ICS LABA. And subsequently, to the lowest effective dose. Yeah, we do not want to lower down and then subsequently patient has attacks. Yeah, so to the lowest effective dose. So I would like to emphasize again, assessment of asthma control should be performed before considering stepping up and down the treatment algorithm. SABA should be taken with inhaled corticosteroids. Treatment should be stepped up to achieve good asthma control. If asthma control is achieved at 3 to 6 months reassessment, we consider stepping down treatment to find the lowest effective dose. So take home message, initiation of treatment depends on asthma control and symptom frequency. Treat to achieve asthma control and find the lowest effective dose to minimize side effects. And don't forget non-pharmacological management such as smoking cessation, regular physical activity, and weight reduction should be initiated. So again, our last message, no more SABA monotherapy, all should be on ICS containing therapy. With that, I thank you.
Thank you very much, Azila, for your very stern lecture on no SABA monotherapy. I hope that for the people in the audience, you will remember that very, very clearly because we feel very passionate about that. Right. So thank you, Azila, for joining us. Now I'd like to invite our next speaker, who is like to introduce her. She's Dr. Nida Ulhuda Adsnan. She's an acute internal medicine physician from Hospital Selayang, and she will bring us through from stable asthma. We're now moving to asthma exacerbations and appropriate referral in primary care. So with that, I'd like to invite Dr. Nida to.
Yes, Assalamualaikum warahmatullahi wabarakatuh and very good evening to all. Thank you, Dr. Prof. Andrea, for the kind introduction. Thank you to Mahtas and MMA for organizing this webinar. And today I will be discussing a very practical and important topic in primary care, which is asthma exacerbations and appropriate referral. So asthma is a common condition that we manage almost daily. However, when patient deteriorate, the window for effective intervention can be very short. And many poor outcomes are actually not due to lack of knowledge, but more of due to delay in recognition or treatment. So today, I will be focusing on what really matters in our clinic setting, how to act early, treat effectively, and recognize when a patient needs urgent escalation. Okay, so today's focus is on the 5 key priorities for exacerbation and management in primary care. By the end of this session, you should be able to recognize an asthma exacerbation quickly, identify high-risk patient, and also perform a rapid but effective assessment, as well as initiating immediate treatment, including our SABA, as well as systemic corticosteroids. So equally important, we should be able to confidently identify red flags that require urgent referral and ensure safe discharge with appropriate follow-up if patient improve clinically. So this entire session will be built around these 5 key priorities. So as an asthma exacerbation is actually defined as a progressive or sudden deterioration of patient's symptom from their baseline. Patient may be presented with increasing shortness of breath, wheezing, chest tightness, or persistent cough. And these symptoms are actually a reflex of underlying airway inflammation as well as bronchoconstriction. So the key point here is that asthma exacerbation is a clinical diagnosis. You do not need to wait for peak flow measurement or even your blood test or imaging before starting treatment. So whenever we see a patient with asthma exacerbation, it is crucial to ask ourselves whether they fall into a high-risk category. So these high-risk patients include those with history of previous intubation or ICU admission, if they have frequent hospital visits or hospitalizations, including ED visits, overuse of reliever or inhaler, and also poor adherence to inhaled corticosteroids. These are the patients who are particularly vulnerable, and even if they appear stable initially, they can actually deteriorate rapidly. And recognizing this group early should actually lower our threshold for aggressive treatment and referral. So in primary care, our assessment must be rapid and focused. The key principle is actually simple. Do not delay treatment for a detailed history. So we can always refine our assessment later, but the initial management must not be delayed. So our vital signs, especially our oxygen saturation, should be checked immediately. We should also quickly assess the patient's ability to speak and their level of consciousness and signs of respiratory distress such as use of accessory muscles. So a very important clinical indicator is speech. If a patient is unable to complete full sentence, we should actually consider that this is severe exacerbation until proven otherwise. So I'm going to bring all of you to this algorithm tree, which we already presented in our asthma CPG on the management of asthma exacerbation in primary care. So the components that we are going to assess will include conscious level, speech, respiratory rate, pulse rate, blood pressure, accessory muscle, breath sound, SpO2, as well as ABG, if it's available at our respective center. So we'll first focus on the mild exacerbation, whereby patient will be alert, having a normal vital signs, and the only two things that may be abnormal is the presence of wheezing, as well as use of accessory muscle. So for the moderate asthma exacerbation, patient mainly will remain alert with a normal blood pressure. However, the vital signs have all become abnormal. The respiratory rate will increase. The heart rate will start becoming tachycardic. Patient may speak in phrases, and the SpO2 will start to be between 90 to 94%, and it will show abnormality in your PaO2 as well as PaCO2. So for a severe asthma exacerbation, you may have a patient who is still alert, or they may actually become confused or drowsy. They'll be speaking in words. There will be worsening of the vital signs, including either a normal or hypotension of the blood pressure. There will be evident use of accessory muscle, worsening of the wheezing. The SpO2 may be less than 90%, and a even worse reading with a PaO2 of less than 60 millimeter mercury and a PaCO2 of less than 40. So for life-threatening asthma exacerbation, patient may be confused, drowsy, or in coma. They may not be able to speak, and you will see a lot of paradoxical in the vital signs, including a bradypnea, bradycardia, or even cardiac arrest, hypotension, paradoxical chest movement, or even an absent chest movement, a silent chest on auscultation, an SpO2 of less than 90%, and you will start to see not only type 1 respiratory failure, but they will start to have CO2 retention, showing evidence of both low in PaO2 and high in PCO2, or a type 2 respiratory failure. So priority 1, which is the most important principle in asthma management or asthma exacerbation, is that the treatment must be started immediately based on clinical severity. You do not need to wait for objective measurement if the patient is clearly in distress. So rapid clinical assessment of the severity is actually sufficient to begin, especially all the life-saving therapy. So in primary care, you have these 3 main treatment tools. First is our short-acting beta-2 agonist. This is our first-line treatment. And in mild to moderate cases, a pressurized metered dose inhaler with a spacer is actually as effective and preferred over a nebulizer. Of note, remember that oral SABA should never be used for exacerbation due to systemic side effects. So a no to oral SABA. Second is the oxygen therapy. This should be given if the patient is hypoxic with a target saturation of at least 94%. And third, and very importantly, is the systemic corticosteroids, whereby prednisolone of 0.5 to 1 mg per kilogram up to maximum of 50 milligram. So one structured approach you can use in the 60-minute SABA stacking cycle, where you repeat doses every 20 minutes and reassess after 1 hour. So the SABA must be continuously be driven by oxygen with a strict 20 minutes interval. So for example, we give an initial SABA dose plus our stat dose medication. We wait after 20 minutes and repeat the SABA dose, and then wait another 20 minutes, repeat another SABA dose, and then only at 60 minutes after the completion of 1 hour cycle, we re-evaluate the patient clinically and decide on the clinical trajectory. Systemic corticosteroids are the cornerstone of asthma exacerbation management. They actually reduce airway inflammation and accelerate recovery, and most importantly, prevent relapse. Steroids should be given early in all patients with an exacerbation. And oral administration is just as effective as intravenous and is actually more practical in clinical setting. So a typical duration is actually 5 to 7 days, and tapering is actually not required. So a key mistake to avoid is actually withholding steroid, and this actually significantly increases the risk of relapse. So this is the continuity of our algorithm tree, whereby in mild cases, as I've mentioned, we have SABA, prednisolone, as well as control oxygen if indicated. Similar, in moderate exacerbation, we give similar treatment, but what is important is after 1 hour, we need to reassess. And the 1 hour mark is the key decision point. We should evaluate whether patient's symptoms have improved or whether their oxygen saturation has normalized. If the patient shows clear improvement, we may consider discharge with appropriate precautions. However, if there is no clinical improvement or if the patient deteriorates, this is an indication for escalation and referral. So always look at the overall trend rather than relying on a single measurement. So one of the most important roles of primary care is recognizing when a patient actually needs urgent referral. You should refer immediately if the patient has severe or life-threatening features showing no improvement after initial treatment, or deteriorates at any point. So other indicators include excessive SABA use prior to presentation, example of use of more than 8 puffs of SABA prior to presentation to your center. And while waiting for transfer, treatment must be continued. The key message is not to wait passively. Active management must continue while arranging for transfer. So in severe or life-threatening exacerbation, management must be aggressive and immediate. Just now, when we talk about mild and also moderate asthma, we talk about the 3 tools. However, for severe and life-threatening asthma, we have these 5 pharmacological arsenal, whereby we start with oxygen-driven nebulized bronchodilator. We also add on ipratropium bromide bronchodilator. We may add on actually ipratropium bromide together, and at the same time, arrange for an urgent transfer to the nearest hospital. We have to ensure that oxygen should be delivered with a target saturation of more or equals to 94%. We may consider given IV hydrocortisone 100 mg IV stat if they are not being given prednisolone before. And the final one is giving IV magnesium sulfate of 2 grams through an IV infusion over 20 minutes as a single dose. This is something that we have added on in our CPG for the primary care management on asthma exacerbation. The principle here is to stabilize the patient while preparing for transfer and not to delay one for the other. So this is the algorithm for our acute asthma management for severe and life-threatening category. This is the 5 pharmacological arsenal that I have actually mentioned before. And if you notice here, if patient does have clinical improvement, we have to continue treatment during transfer and monitor progress. However, with the patient actually showed no clinical improvement after treatment with the 5 pharmacological arsenal, we need to consider intubation if the patient conditions deteriorates. Okay, so if the patient presented with life-threatening asthma even at the presentation, please do transfer to the nearest hospital immediately. So discharge should only be considered when the patient has clearly improved. However, safe discharge actually involves more than symptoms resolution. And you must ensure that the patient actually receive a full course of oral steroids, has their inhaler technique checked, and also understands their medication. An asthma action plan should be provided or updated, and follow-up must be arranged within 1 to 2 weeks. Failure to address this aspect is a common reason for relapse and readmission. So beyond the acute episode, long-term management is essential. This includes patient's education, trigger avoidance, education on self-monitoring, a regular review, arrangement for a regular review with scheduled periodic checkups to assess control, adjustment of treatment, as well as update on the asthma action plan. And a good primary care management can significantly reduce further exacerbation and improve quality of life if we also emphasize on the lifestyle modification. So integrate these pillars into our routine care to improve long-term outcome and quality of life. So to summarize, asthma exacerbation management in primary care revolves around 5 key principles: assess rapidly, act decisively, ensure we give steroids early and to all patients, recognize when to refer, know our own limits, and ensure safe discharge and follow-up. If there's one takeaway message, it is this: early action saves lives. With that, I thank you.
Thank you very much, Nida. I think that was very comprehensive. Also, the pictorial thing actually helps us to understand something and make something difficult sound easy, right? So I think we're all smarter now before and after Nida. So we're going to be even smarter now by moving to the fourth lecture for this afternoon. I'm very privileged to have with us a pharmacist. She's a sole pharmacist in this room, so if there's any problems, she will be able to solve the problem for us. She's a pharmacist in Hospital Sultan Idris Shah, Serdang. She's Miss Chong Lien. She was in the two previous CPGs together with me. And if you don't already know her, you can actually watch her YouTube videos, right? So she will bring us through a title of a lecture, Patient Education, Self-Management Skills Training in Asthma. Lien.
Hello, everyone. My name is Lian. I'm a pharmacist from Hospital Sultan Idris Shah, Serdang. Today, I will be discussing on the patient's education and skill training based on the CPG management of asthma in adult. Before we start, I would like to ask a question. How many of your poorly controlled asthma patients are due to not optimized treatment? Very often, actually, the issue is not the drug. It's because of patient misunderstanding, poor inhaler technique, or poor adherence. That's why, so today, we are going to focus on how to fix that. By the end of these sections, we aim to understand the key component of effective patient education, skill training on effective use of inhaler device, explore strategy for improving patient adherence. The main goal of patient education is to provide patients and their families or other carers with suitable information and training on asthma management in partnership with their healthcare provider. Here, I would like to emphasize the word partnership because the asthma is not managed in the clinic actually. It's managed in the patient at home, at their work, or at school. We only see the patients every 3 to 6 months for 10 to 15 minutes. But the asthma patients, they live with the disease most of their life. The 4 components of patient education are asthma information, guided self-management, skill training on effective inhaler use, and adherence improvement. Asthma information is an essential component of patient education. There were many times during my shift working at the ED pharmacy counter, I met patients with asthma exacerbations who didn't understand the need to getting follow-up and getting an ICS started. Some would tell me that it's okay, whenever I have attack again, I just come back to the ED. Just like what I did today. It's quite sakit hati. It highlights that patient's education is essential. It's not optional. Inside the CPG, we have this checklist. That's the information that we should give to the patients, and they include patient information about asthma. What is this disease about? It's a chronic disease. The pharmacotherapy, there are differences between their blue inhaler and their chocolate inhaler. The non-pharmacotherapy, smoking cessation, and importance of adherence behavior. This checklist is readily available in the CPG. You can use them when you're giving education to your patients, so you won't miss any important information. You even can use this information, this checklist, to design an inpatient information leaflet to give to your patient. Guided self-management is an active process which involves a dynamic collaboration between patients and provider. Our role is to guide and support the patients by providing education, the tools for them that they know how to self-adjust the treatment at home and give them ongoing support. With that, the patient will develop self-management competency. They will gain skills and confidence to manage their disease independently. So you may ask me how to implement guided self-management. Asthma Action Plan, AAP, is the practical approach. Asthma Action Plan will guide the patient to self-monitor their symptoms or by PEFR if the patient has a prick flow meter combined with regular medical review. And this has shown that it can reduce the ED visit and hospitalizations rate. Asthma Action Plan is a very effective tool. However, it still remains underutilized, mainly due to two reasons. First, the design is usually unclear to the patients. Patients don't understand. Second, many healthcare providers unsure how to complete the Asthma Action Plan. To address this, the CPG has designed the Asthma Action Plan with separate column for reliever and controller, helping the patient better understand the difference between these two. And then for the yellow zone, the rescue doses already pre-filled. The dose already pre-filled according to the evidence and the practice. You may notice that the design of the AAP is not that colorful. It's intentional, in considering that some center may not able to print it in color printing. They have to print it in black and white. In the CPG, we have two templates to suit the different regime. First template is for separate inhaler for reliever and controller. And another one, the template for MAT therapy, maintenance and reliever therapy. I will use this scenario to explain on how to use the Asthma Action Plan. This is in patients on PMDI salbutamol 2-puff PRN reliever and PMDI budesonide 2-puff PD controller. When patient in the green zone, patient is well, with all this no cough, wheezing, chest tightness, symptoms well controlled, patient have no need to use their blue inhaler, which is a reliever. But they have to continue using the controller, the brown PMDI, for example, as the dose that's prescribed. When the patient has to get some symptoms, which is in the yellow zone, as listed in the Asthma Action Plan, patient can start to use reliever. The dose already pre-filled in the Asthma Action Plan. Patient will advise to take 2 to 4 puffs every 20 minutes of their blue inhaler for a doctor 3 times and assess the symptoms. If symptoms of PEFR is improved, patient can lengthen the interval to every 3 to 4 hours as needed, and the duration may be further lengthened based on continued good response. But if symptoms is worsened or persist, proceed to the alert management. During the yellow zone, the AAP clearly states that the controller must be continued to be taken. In the alert zone, which is a dangerous zone, the patient has advised to proceed to the nearest hospital or clinic immediately, and during the transfer, the medication still can be continued with spacer. Increase the reliever dose up to 10 inhalation every 20 minutes. If patient without a spacer, take 2 inhalation every 5 minutes. Same controller need to be continued. How about for patients using MAT therapy? And asthma patients on budesonide formoterol, 1-puff PD and PRN, for example, when they are well, they have no need to use the reliever, except if before exercise it's the one to use as a prophylactic dose. But they have to using their controller every day, even though the patients are feeling well. When the patient getting worse of their symptoms, don't wait. They advised to take 1 inhalation of their budesonide formoterol tube inhaler as needed to a maximum 12 inhalation a day, including the controller dose. If symptoms are worsened or persist, proceed to alert management. In the alert management, the patient have to advise to proceed to the nearest hospital or clinic, and during the transfer, patient still can continue to take 1 inhalation every 1 to 3 minutes up to 8 inhalations. Skill training on effective inhaler use is another essential component for patient education. There are many types of inhaler available, and they can group into 3 categories, which is pressurized middle dose inhaler, for example, PMDI salbutamol, PMDI budesonide, PMDI Foster. Soft mist inhaler or Respimat, such as Spiriva Respimat, Spiotol Respimat. Dry powder inhaler, we have a lot. We have Sympicort tubular inhaler, Seretide acute inhaler, Foster next inhaler, Altipro breath inhaler, Anora ellipta, and easy inhaler. All of this, each of them got their own advantage and disadvantage. So skill training is very important to reduce the inhaler errors. And these are the errors that have been associated with uncontrolled asthma. For example, PMDI, actuation before inhalations, incorrect preparation of the second dose, such as without proper shaking before the second dose, exhaling into the mouthpiece, or not holding the device upright. All these are associated with uncontrolled asthma. Dry powder inhaler. The main errors that link to uncontrolled asthma is insufficient inspiratory effort. The correct technique is that patient need to inhale strong and deep inhalations. Weak inhalation is linked to poor asthma control because it fails to generate the required inspiratory flow rate to deaggregate and inhale the powder effectively. So we must follow the principle of effective inhaler technique education to make sure the patient get the optimal dose from their inhalers. First, training of ourselves, training of the healthcare professionals. We all must know how to give correct instruction to the patient. Select the appropriate inhaler device for patients. Visual demonstration, not verbal. Teach to go. After visual demonstration, ask the patient to show us back the technique and then we correct accordingly. Then continuous monitoring and periodic reinforcement. I would advise to use algorithm when selecting an inhaler for patients. For example, this algorithm that I always use in my clinic is called ACT algorithm, Assess, Choose, and Train. The first part of this algorithm is to choose the inhaler based on the patient inhalation maneuver. After that, we check the patient ability to use the certain device. How to check the patient inhalation maneuver and decide on the inhaler type? So at this stage, you just ask the patient to perform 2 inhalation maneuver without using any device first. First, ask the patients to inhale slowly and deeply, then inhale forcefully and deeply. Then you may ask, what's the difference between these 2 inhalations? How slow is slow? I always use timing to guide my patients. Inhale slowly and deeply means inhaling over 3 to 5 seconds, just like this. If inhaling forcefully and deeply is inhaling 2 to 3 seconds, like this. That's the difference. After observe the patient, we ask the patient which inhalation maneuver the patient more comfortable. If the patient can inhale forcefully and deeply by observations and patient also think it's quite difficult to do it, then choose a PMDI or soft mist inhaler for the patient. If by observation is still not unsure, these are the tools that you may use. These are injectile, the tubal halo whistle, and some feedback mechanism. Some inhaler come with feedback mechanism. After assessing the patient inhalation maneuver, we check the ability of the patient to use a particular device. You can show it yourself by visual demonstrations, or you can even use effective tools like video. Ministry of Health, in cooperation with Malaysia Thorax Society, have this inhaler video available in the YouTube. You can get the videos just by scanning the QR code. You can share these videos with your patients in the clinic. You can let them bring back, give them the QR code or the link so they can watch the video and learn the technique at home also. Inside the video, that features all these clear and complete info for the patients. The inhaler description, the parts of the inhaler introductions, how to check the dose balance, and the inhaler technique, and even cleaning of the inhaler. In the CPG, we also have this checklist, which is very useful for you when you are checking your patient inhaler technique in the clinic. By having this table, you can check, is there any patient doing any step wrongly, mistakenly during your assessment. The next essential component of patient education is adherence improvement. Before we improve the patient non-adherence, we must assess the patient adherence pattern with proper tools. Patient-reported outcome instrument, PROS, or questionnaire are simple and timely, inexpensive tools that can be used in clinical practice. And the one already validated include this questionnaire called Thai questionnaire, Test of Adherence to Inhaler. It is available in English and also Bahasa Malaysia. This is the Thai questionnaire. It consists of 10 questions, and the full mark good adherence is 50 points. Yes, patient must get full marks to qualify as good adherence. But actually, the score is not the important thing that we should look at. By asking the patients to answer these questions, we can identify which part of the patient's non-adherence and what's the cause. Then we can tackle with strategies. And types of non-adherence can be categorized to 3 categories. Erratic non-adherence, which is caused by forgetfulness due to disorganized or very busy lifestyle. Unwitting non-adherence, patients who actually don't understand or unintentionally misapply the medication instructions. The last one is so-called intelligent non-adherence, but I don't think they are intelligent at all. It's patients intentionally not taking their medication as prescribed for reason, including the fear of side effects such as steroid, and not feeling sick or high cost. Erratic non-adherence. Inside the CPG, we already list out the suggested improvement strategy that you can tackle the erratic non-adherence caused by forgetfulness and also on. So, for example, most of the patients will tell me that I always forget to take my morning ICS dose because I was too busy on the way to go to work and all that. So I would suggest them to link to daily habit to keep their ICS beside their bed. Once they wake up, they take their ICS first, then only go to brush their teeth because after using the ICS, memang they have to rinse and gargle the mouth. And then at night, before they brush their teeth and go to the bed, they take the inhaler again. So that's how we tackle the erratic non-adherence. How about for unwitting non-adherence? They don't take the medication actually because they don't know. There's a lack of education. This is the part that we need to educate them more. We simplify the regime. We give them asthma action plan so they get some guidance for them to follow. For the last, intelligent non-adherence. For example, I have this case on Monday. This patient, an engineer, so angrily telling me when I correct her inhaler technique, she said, since you say my inhaler technique is not good, how come I have been so well controlled all this while? But actually, she's admitted this time for exacerbations. This patient, you have to sit down calmly, explaining to her all about the disease and what's the indications of the medications and so on. So it's not easy, but we still have to do it. So who can provide the patient education? Not only pharmacists, everyone can do it, including all of you inside these virtual sections. Of course, pharmacy side, we have this program called Respiratory Medication Therapy Adherence Clinic, MTAC, which is in collaboration with other healthcare providers. We provide educations, monitor the adherence, and resolving medication-related problems. And our MTAC have been proven can achieve better control asthma, and majority of the patient will be master good inhaler technique after this program. So take-home messages. Patient education consists of 4 components: asthma information, guided self-management, skill training, and adherence. Asthma information, that's the checklist that you can follow inside the CPG on the disease, medication, non-pharmacology, and importance of adherence. And guided self-management involves self-monitoring of symptoms with regular medical review, and of course, asthma action plan. Skill training, inhaler technique. Always check patient inhaler technique at every opportunity, because this time the patient can master good inhaler technique. Once go home, come back, it will become worse again. So always check. Adherence, not easy to do it. Patient always say yes, I'm adhered, but they're not necessarily so, because asthma, when they're getting well, they don't appreciate the medication to take it every day. So that's all. That's end my sections. Thank you very much.
Okay, thank you, Lian. We can see you're very passionate. I'm sure a lot of patients have annoyed you along the way. I see a lot of thumbs up. Thank you very much. So I think we will leave the questions for a little bit later. And we've been furiously answering your questions in the Q&A. So thank you for keeping us on our toes. So now I think I will probably move on to the last lecture of this evening. Okay, we can see my slides. See my slides? Yeah, okay, just checking. All right, so we're going to put all of this in practice, right? And look at case-based discussion, how we're going to apply all these lectures in a patient that we're going to see in real life. So hopefully you'll be more confident in primary care even without spirometry, because I think Nida had mentioned that, or is it Maza? I think it's Azila had mentioned that you don't necessarily have to have a spirometry to diagnose asthma. We hope that you would be able to be confident in starting as well as adjusting the controller therapy with whatever medications available to you. You want to be able to recognize exacerbations early, safely, and know when to refer. And I think probably, hopefully, if you've taken Leanne's advice in terms of looking at the videos and empowering yourself, you'll be able to teach patients the correct inhaler technique and self-management. And the endpoint would be that you will be able to use the document that is known as the Malaysian Asthma CPG to make you more comfortable in terms of managing asthma patients in your care. So I think we cannot run away from the fact that in primary care, majority of patients could be underdiagnosed. They have asthma, but they do not come forward with forthcoming symptoms. And because they are not diagnosed, they are not treated. And a lot of them are managed with SABA only, right? So these are the points that we want to move away from. So our CPG, she emphasizes that try to move away from SABA monotherapy, and also all asthmatic patients should receive some form of treatment that controls inhaled corticosteroids. So we're just going to go through a case presentation. This is Miss S.A. She's a 28-year-old woman. She works in a pharmacy. She's got a 5-month history of recurrent cough and intermittent wheeze. So she says the cough makes it difficult for her to sleep. It's okay during the day. She coughs when she does. And she's got 1 cat for the last 10 years, right? So what is your diagnosis? Again, if we've gone through the mornings, the early afternoon session, we realize that history plays a huge role. And the history looks like there is chronic cough because it's 5 months. It appears to be intermittent, and it appears to have some diurnal variation, and it appears to have some triggers. Yeah, okay. So typical clinical history, we would agree on that. Physical examination, you probably want to see whether there is any wheeze, whether the patient's breathless at that point, whether she's got any cough. You want to have some evidence of variability, whether it be spirometry with the bronchodilator responsiveness test or a PEFR diurnal variation. So spirometry preferred, but it's not mandatory. So we go back to her. You can see that she's got all of this. Now, I probably just want to say something about the cat, right? It is unlikely that the cat is the cause of the problem. And I don't think that we should be very fast to blame the cat. Okay, so before you ask the patient to remove the cat from her life, you should actually go through all the other triggers because she had the cat for 10 years and she only had the cough for 5 months. So if the spirometry is not available, and I think from the questions that we have actually, the initial questions coming in would be how would we recommend and make sure that spirometry is actually used? A lot of it is actually awareness and also availability and also knowing what to do when you have a spirometry. So I've actually mentioned in the Q&A that we have a spirometry certification course, right? So assuming that you don't have the spirometry, the CPG document actually allows you to do what is known as the peak flow variability, meaning that you measure the patient's peak flow twice a day for 2 weeks, and we calculate the variability. If the variability is 20% and more, this shows that the airway is very unstable, right? You can also use a trial of treatment, meaning that you give the patient a trial of inhaled corticosteroids for a short period of time and get the patient to come back to you and see what the response is like. So either you, for the lady, she's got chronic cough, you can give her a trial of ICS and you see whether she improves. So if her nighttime symptoms disappear and she actually is more stable when she doesn't actually have any cough, then this is actually proof of concept. Okay, so I think the main thing I would like to reiterate would be that you do not delay treatment. For example, you tell the patient, oh, you don't have peak flow variability, you come back after 2 weeks, I can't give you any medication. First, you need to do this before we can actually diagnose asthma. No, we try to move away from that. So you should educate the patient on the correct way of using the peak expiratory flow meter, and then you can tell the patient how to use it, where you actually use it morning and night in a seated position, same meter to reduce the bias, also relatively same time of the day, right? So you take 3 readings and you record the highest at each time. So the PEFR, it's known as a diurnal PF variability, where you take the day's highest minus the day's lowest over the mean of the day's highest and lowest, and you multiply by 100. So for example, if your highest that day is 500, your lowest that day is 400, the mean of that day would be 500 plus 400 divided by 2, and you divide this and you multiply by 100, and that will give you 22.2. So this lovely calculation will have to be the average daily variability over 1 to 2 weeks for diagnosis. So you cannot just calculate for 1 day and say it's 22% you have asthma and this is it. It's not negotiable, right? So we do know that your airways, we need to prove that your airways are variable over a period of time, not just in one single moment in time. So if you, I think our document is available on the internet, and if you have a look at the Appendix 3, which is on page 69, the members of the CPG have worked hard to actually give you this example of calculation for you to be comfortable enough should you choose the PEF monitoring for your patient. So I think the take-home message would be that asthma diagnosis is a clinical one, and spirometry, while it supports the diagnosis, it should not delay the treatment for the patient. So Mr. S is a known asthmatic. She's only using inhaler salbutamol daily, which is a big no-no in this day and age, especially, on the 11th of April 2026. You should not have any patients who are just on SABA therapy. I think the reason is because asthma, if you remember Dr. Maza's slides, remember I said it's a bit boring but incredibly important. The inflammation is the backbone. So this salbutamol that you puff is not going to do anything for the inflammation. Therefore, you're just going to not treat the problem, right? So you can have a look at her. You can see that she's not on the appropriate treatment. She's not on any ICS treatment. Her symptoms, therefore, are about 3 to 4 times per week with coughing, and she's got nighttime symptoms. So how would you treat this patient? Do you have enough to treat? Yeah. Do you need to do the PFR variability? Not necessarily. You can actually give a trial of treatment, right? So let's see the trial of treatment. So number one, she needs whatever she needs to be given, that SABA alone. So some people actually say, oh, does it mean that we throw the SABA out completely? No. The key here is monotherapy. We're not saying that SABA is bad. We're just saying that SABA cannot be used alone. You should team it up with ICS. So the treatment options based on the CPG algorithm would be either your PRN ICS formoterol, or a low-dose ICS with PRN SABA, or low-dose ICS with PRN ICS SABA, or just a PRN ICS SABA. So notice there is no SABA alone. Do you see? SABA alone doesn't count. Whatever is happening here, there's always some steroids, right? Formoterol, low-dose ICS, PRN ICS, right? So again, you're probably going to ask in the chat group, so I'll save you the trouble. Which one do we use? Okay. So the choice depends on availability. It also depends on the patient's preference. And because some of these inhalers come in different devices, so if you take into consideration what Leanne has actually just brought us through, the device makes a difference, right? So you can see that, for example, you have a very nice Porsche, but a very old man, so it doesn't really suit the person. Same thing, right? So the old man needs to be in a Kanchil, when the young person needs to be in a Porsche. So ability to use the correct device. If the device suits the patient, that is the correct device for the patient. So in the earlier patient, the patient with the CAT and the chronic cough, a practical primary care prescription would be budesonide, which is ICS, 200 mics BD with salbutamol PRN. You can actually use that. Or if you want to use, you can use PRN ICS formoterol. So again, availability, patient preference, ability to use the device, right? And I think really a lot of times we get swayed with the patient's preference, right? So if the patient likes it, the patient needs to be able to use it, right? If the patient can use it, then this is the correct thing. So I think you have to probably, how do we know that the patient can use it? Is by actually looking at the videos online and then having some dummies available in the clinic to test the patient's ability. And if the patient can use it in front of you or is comfortable with that, then that is the correct way of choosing it. So this is algorithm 2. I think you've seen it already earlier, but I think probably what I want to tell you would be that in asthma, it's not a one way, like up and away, right? Forever. So a lot of people say, I keep adding on and you forget to step down. So let's just have a look. Even the name of the algorithm tells us that if you can, what goes up can come down. There is a step up and step down option in the management of stable asthma. So once that patient has stabilized, so for example, if a patient is on high dose ICS LABA-LAMA, right? You already given triple therapy, for example, and you're going to phenotype the patient. You're going to say, oh, I think this patient actually needs biologics. But when you review the patient becomes suddenly much better, then you do not have to go to biologics. You can actually then drop it to high dose ICS LABA, and while you actually target the triggers in the patient, if the patient continues to improve when you next review, you can actually cut back the dose of ICS, high dose ICS LABA to medium dose ICS LABA. When the patient then sees you, it's compliant to treatment, technique is much better, you consider stepping down. Now, at this point, let's say medium dose ICS LABA and the patient is symptomatic, right? Before you consider stepping up, take a look, ask the patient whether the patient is using it and make sure that the patient is using it correctly. If the patient is not using it, there's not much point increasing to high dose. The patient needs to stick to medium dose ICS LABA and continue to use it. So patient was started on budesonide inhaler, 200 mics BD and salbutamol PRN. Comes back 1 month later, still symptomatic, unhappy with your treatment. Yeah, there are a lot of patients like that. I think, I'm sure you have patients who are unhappy with you. So what's the next step? I suppose I've mentioned it earlier. Next step is make sure that she's using the correct inhaler, make sure that her technique is correct, she's adherent. Also make sure that she doesn't have any new problems, any new triggers. And perhaps you want to take time to actually get history to see whether this is indeed asthma or not, right? Assess your adherence, the inhaler technique, risk factors. And if all of this is addressed, right, then you can step up to ICS LABA. Right? So this is the step up, step down that I've actually mentioned earlier. So asthma exacerbation in primary care, I think Dr. Nida mentioned in great detail. I was, listening. I think if you had paid attention, then this slide can just go on to the next one. But okay, we're going to assume that we want some reinforcement, right? So you can have a look. Her slides are better because she did Gemini, right? So I haven't actually moved on to Gemini. So this is snapshot of the asthma CPG. So she's severely breathless. She's unable to complete sentences, and the SpO2 is 92. Remember, we said 94. So she's in asthma exacerbation. What do you want to give? You want to give your SABA, and you get 20 minutes, and then you assess up to a full hour. You want to start her on prednisolone, and her sets are 92%. You're going to slap some oxygen in her to keep her saturation 94%, and you're going to give systemic corticosteroids, right? So this is exactly what she has mentioned, and now it's come to fruition in this patient who actually presents with exacerbation. So I think probably you want to worry about when to refer. When your patient's symptoms are severe, so medicines and art, and all of you are doctors, right? So you know when the patient is not responding to treatment. You would have seen enough patients to know that at this point they would probably have improved, right? And you look at the patient overall. So let's say her saturation improves, but she begins to tire out, right? So that again, you don't look at one single parameter. It means that she's not really improving. So you want to refer. Any life-threatening features that the patient has in terms of if you have ABG, the saturation, whether she becomes drowsy, whether she becomes more tachypnic, then you want to refer the patient. So I think that your inhaler technique, it's an important point because the majority of patients need to have some form of remedial when they come to you in clinic. So never assume that the patient's got good inhaler technique. I suggest that you look at the YouTube videos. What I normally do in clinic is I open up the videos and I show the patient, and I also open up the patient's phone to actually send the link to the patient's phone so that they can actually continue to look at the inhaler technique when they go back home, right? Because you can see that there's this waning effect. You teach the patient, they go out the room, the knowledge goes down. By the time they take a grab back, the knowledge goes down even more. By the time they go back home, they might have forgotten what you have actually taught them. So just remember the asthma is a clinical diagnosis. ICS is important. Do not use SABA monotherapy, and you want to assess the control and also your adherence before you slap the patient with a higher dose ICS LABA. Treat exacerbations early. Certainly, you must use systemic steroids, and whatever is, do not go away from patient education and inhaler technique. Okay, so I've come to I'm going to unshare my slides because I'm moderating myself, right? So good job. It's very difficult. Let me just see. I think now, good job, huh? So, okay, now I'm just checking. How are we for time? Now is 3:40. Oh, right on the dot. No, I'm pleased with myself. All right. I see some thumbs up. Thank you. And a clap and a love. Oh, dear me. Okay. All right. So thank you very much, everyone, for going through the 5 lectures with us. Now we come to quite an exciting part. We are going to test your knowledge. And I believe that there is some gift at the end. So when you join, can you not give your nama glam? You must have your email.
Full name atau MMC.
Okay. Email or full name or MMC number. Okay, not like, inhaler queen. No, no, no. Because when you win, we have no idea who you are. So again, it's actually your email or your full name or MMC. All right? Okay, so she's going to, Dr. Ayuni is here and she's going to share the screen. Okay, all right. So we've actually so what we want you to do would be take your phone, scan it, and you will be brought to the link, and there will be questions there, right? I promise you they're quite easy because Ayuni and I.
Top three will get prize.
Okay, Ayuni is beside me, but she's camera shy, so she has forced me to tell you this. So the top 3 will be, so only 3 people. So as it is, like, you want to be the top 3, otherwise don't bother, right? So let's try very hard to be top 3 in this. I think it's quite nice to actually see how good our knowledge is, right? Okay. We've actually done a mock. Ayuni did quite well. So, yeah.
156.
Okay, there are many people in. Thank you very much. We're all very excited. Yeah, I think you're quite a good crowd. You really keep us on our toes with the questions. Thank you very much. Okay, more questions coming. Oh dear. Okay, all right. So maybe we'll just give ourselves another minute and then we will start, all right? Because I do realize that sometimes you are on your phone, you want to switch to the computer, or you want to charge your phone, or you want to go for a toilet break. All of it is acceptable, right? Yeah, so this is also on FB Live as well on the MMA. So if you want, you can actually look at that there and give us some positive comments, right? So while we're waiting for another minute, I hope you're all enjoying your lovely Saturday, spending it with us. Thank you very much. Someone actually put a floating brain, so I'm not sure about that. Does it mean your brain is floating because it's full of knowledge? I'm not sure. But okay, well done, well done. Yeah. Oh, there's a lot of love, all right. The love I can understand. The floating brain is a new thing. Okay, oh, there's a sad face as well, is it? Oh, okay. Yeah. Yeah, thank you for giving me all this, all of us, these emoticons. We're really happy. You should see our smile. Only I have the video on, but I think everyone else is smiling as well. Should they? Oh, there's a lot of love. Oh, okay. Yeah, Miss Lian is very happy with it. Yeah, so yeah. Don't forget when you go, if you happen to want to see her YouTube channel, you can also subscribe, s- be a subscriber, so then she can earn some money from it as well. Okay, I think we have 382 participants, 384. Oh, you people are really good. 385. 86. Oh, dear me. Okay, all right. We have to put a cap to it. 87, 88. Okay, okay, all right. I hear you. Okay, for those of you doing these emoticons, I hope you've already joined this. Don't emoticon away, not join. Sad. Oh, I see. That's all.
Mula sampai dia berhenti sekejap.
Okay, we will stop when the numbers stop climbing because we want to give you good chance, right? Three hundred and 99, 400. Wow, okay. 401. Okay. 402. Very good. Thank you. Keep the numbers coming. This is like voting, right? Okay. How many participants do we have?
500.
We have 500 participants.
Facebook pun boleh je.
Facebook also can join as well. Right. Betul. Okay, I'm also 420. Oh, guys, you're really good. How do I give an emoticon as well? Oh, these emoticons just keep coming, I must say. Very good. Okay, we're going to start 429. Ayuni is very eager to start, and for today she is the boss of this question and answer. So if she starts and you're not in, it's not my fault. Okay. Okay, Ayuni. Right, we're going to start 430. Oh, wow, the numbers keep coming. Ayuni, kejap. Dia hampir 441. Okay lah, 441 boleh. Okay, good luck everyone. I'm giving you guys music.
Extra.
Kena buka mic, tak buka mic. Gerak dah. Gerak dah. Okay. 15. Macam lama pula. Tak sebab tadi dia tak ada. Untuk dia share music lah.
So sad. But if I put here, then it will be on.
2, 1.
Oh.
Oh. I tell you, you can see from the MMC number whether they are young or old.
Then the answer.
Oh, explain the answer. No, I don't want to explain the answer.
Concentrate.
Yeah, concentrate on this first. Okay, all right. I can see that most of you are answering quite well. So that shows that we have given our Saturday up not for nothing. Can so which is a typical asthma symptom? Okay. So I think this one most of us would probably be quite familiar with, right? Because you've got a lot of patients who come in. So the key word here is typical, right? So of course, because human beings are made differently, there's always an atypical way someone with asthma can present. But when you talk about typical, then I think the answer to this question is a little bit easier. Okay, so I think some of you, I think maybe the internet is a little bit slow. Do agree? So it's time to actually update your internet. This is good reason to do that. I myself have just updated my internet recently. I can see that you're all working hard because those emoticons have stopped, right? How do you do the emoticons?
Yeah.
Yes, yeah. All right. One up. That's me over here. Listen. Yeah. Oh, more. They're coming. Oh, thank you. I rather you answer the question rather than give the emoticon. Stop it. Answer the question. Oh, there's a lot of hearts now. Okay, thank you for your support. Okay, Ayuni, maybe we can move. think so. Thank you for the hearts. Okay. Oh, I'm done. Okay, so this one is about management, right? All asthma patients should receive antibiotics, ICS containing therapy, oral steroids long-term, SABA only. So I'll give you a clue. Please do not answer the red one. I will be very sad, right? Because that's the whole key to that. So it's, you now have a 1 in 3 chance of getting it right. Okay. Oh, someone is laughing. Oh dear. Okay. It's true. Okay. I've narrowed down your choices. Please do not pick the red. All right. Oh, is it? So the color is different, is it? Oh dear. Okay. Please don't listen to me. Sorry. I didn't realize that the color is. Oh dear. Okay. All right. I hope I have not cost any of you the crown. Okay. Okay. All right. Remember, don't press the emoticons. Answer the question. Okay. Remember, don't press the emoticons. Answer the question. Oh, yes, that's a lag. Ah, thank you. Okay, all right, okay. So important point, this one I nak mencelah lah. I think all asthma patients, the reason SABA only means SABA monotherapy. So I think maybe it's a play of words, right? So I hope that the 8 who've answered SABA only will realize that actually the answer cannot be that because you should not give SABA alone. It has to be with something. And remember, we talk about inflammation in the airway. So no matter what you pair it up with, you must have an ICS containing therapy. So the 338 who answered that are correct. Well done to you. Let's move on to the next question. Okay, so which is not recommended? Which is not recommended? No, dear. Oh, there's a lot of people smiling until they have tears down their eyes from the emoticon. Not sure about that. Yeah, okay. Okay. Oh, and okay, we ended. End timer. Cannot end timer. Oh, okay, we have to go through. But the timer is stuck.
No, but because like there's a lot of people coming in,
Oh, I
so
see.
there's lagging in terms of
Okay, all right. There appears to be some traffic due to popular demand of this thing. Yeah.
dekat Facebook berapa orang tadi.
Oh, I'm not sure.
Mhm.
Okay, while it's stuck, I'm checking Facebook to see whether you guys how many people are watching. Oh, okay. So we actually have 132 people watching on Facebook.
100, 600.
So I think unless there's double, we have quite a large crowd. There's 137 out there on Facebook and us in here as well. Yeah, so I think you are causing quite a bit of traffic. It's macam nak pergi beraya makan. Oh, somebody said Sabah monotherapy orange color lah. Yes, yes, I do agree that the color I have here, I already said it just now. So for the person on Facebook, think. No comment. Oh, no comment. Oh, I see the comment. Sabah monetary. Okay, well done. Okay, all right. Okay.
The 4% who answer other
Yeah,
than the
yeah,
Sabah.
betul. Okay, so before stepping up treatment, remember what we said before stepping up treatment, right? So just remember the lecture that you received from our sole pharmacist for this afternoon, right? And then you'll be able to answer it correctly. And this is it's an important thing, which I hope you will also practice in your everyday life, right? That before you actually want to escalate therapy, you should do one of the following here. I won't name the colors because I realize your colors are different. Someone's answered in Facebook Live. Well done. Okay. Yusrizal Roslan, Oscar Lee, Meiji. Oh, well done. Okay. Yeah, so there's a lot of traffic again. So for those of you who are watching live on Facebook, have to. Yeah. So thank you for answering on Facebook Live as well. Appreciate that. Yeah, so Siti Chai has also answered. Okay, thank you for answering. Oh, someone's given a new emoticon of a Malaysian flag. Right. It's nice.
To download.
I don't know.
You know,
And there's also a birthday cake. It's nobody's birthday, but thank you.
emoticon je.
Okay, for those of you,
It's
okay,
4 o'clock.
right. Okay, so adherence and inhaler technique. So Miss Chong Lian did a good job, 339. Chest X-ray is not indicated. Blood culture also not. So I presume maybe you were a bit excited and you click on it accidentally. So I'll give you a discount. Can't click on. Okay, all right, no problem. Sometimes it's like that. And I've done it before, accidentally click, right? Okay, asthma exacerbation with a SpO2 of 92%. Immediate. What is the immediate treatment? Right. So this is going back to Dr. Nida's lecture, and she was very clear about a lot of things that you have to do. All right. So remember the cutoff is 94, right? So immediately patient is a little bit hypoxic. Okay. Okay, so we've got some people already. Oscar on Facebook has already typed in his answer. All right, thank you. All right, so it has Meiji Izumi. Okay. Okay, let's have a look. These emoticons keep coming. I think the members of the panel would like to know how do you get the different emoticons, right? So maybe you can let us know in the chat. Oh, okay. Someone said green color. Okay, I hope your green color is my green color. Okay. So Yusrizal, Siti Chai, Kugan, thank you very much for participating on Facebook Live. Maya answering. Oh, someone had given an emoticon of 100%. Well, I hope so, that you have 100% benefit from this afternoon session. Yeah. So I do apologize. It's a little bit slow. I think it's because of the many people who are also attempting to answer. I just saw an emoticon of a mushroom, so I'm not sure why. Maybe you care to hungry. Okay, right. Or there's an emoticon of a hospital as well. Okay. Okay, Akila Azaha has also answered. Thank you, Akila.
I get an attendance form. I get that.
Yeah, so in between all the answers, there's this worry about the attendance, and I think Tuan Zamani has actually sent the link again. All right, systemic corticosteroids, well done for the 328, as well as the people on Facebook who've answered. So Facebook was 100%. All those ones who answered. Okay, moving on to the next one. Most important component of asthma education. Right. Avoid inhalers. Okay, we've given you the incorrect answer already.
That's the easiest.
Yeah.
Boy, Mr.
Yeah. Okay, that was a joke, by the way. Right? Okay, so just in case, please do not take us seriously. Okay, waiting for your answer. Yes, I can see a lot of people laughing until they've got tears down their eyes. And the hamburger as well, thank you. You know where we are? We are actually in KKM, so if anybody wants to grab some food to us, you may. Block E1, thank you. To the lobby. Okay, so again, we've got Oscar Lee who've answered, Noor Aliana Ismail, Kugan Chandran, Yusriza Roslan. Thank you very much for your for answering and participating on Facebook Live. Yeah, so the lag is, well, it gives us an opportunity to get to know each other, right? We get to know each other on Facebook Live as well as your emoticons. So Umira has also answered. Meiji has answered as well. Siti Chai has answered as well. Oh, okay. Thank you for sending us the food emoticon. We appreciate that. I see that flying out. Thank you. Oh, thank you. Sushi is good. Eggs are good. Is there any egg? Okay, eggs are good. Oh, it's ice. Oh, that was ice cream. Okay. If it's ice cream, I have and pizza and chicken. All right. Okay. Thank you. Watermelon. Oh dear, too many. All right. There's a tomato as well.
Caramel.
Oh, okay. It's quite a lot. Oh, coffee. Thank you. Whoever sent the coffee, I appreciate it. Prawns, no, I'm allergic to prawns. Carrots are okay. Okay, is that beer? No, thank you. No. A root beer, all right. Okay, think good thoughts. And there's pear as well. Okay.
Turtle. Ice cream.
Oh, there's a little chicken. Okay, and a strawberry, as well as a cake. And there's an octopus as well. And fish. And
Donut.
there's it's a turtle. Okay, no. We reject the turtle, but everything else is fine. Is that lamb? Okay, lamb is all right. Lamb chops are good. Chocolate chip is good as well. And the turtle comes back. All right. So I'm going to ask Ayuni what is happening on your end. Oh, Ayuni says we are rather stuck. Oh, someone sent us a rose. I think the rose is for you, Ayuni, to unstuck ourselves, please. Teach inhaler technique. Well done. 303, right? Avoid inhalers, I think is our fault. So I'll read okay. So it's not used. So the main thing of asthma education is actually the inhaler technique. Okay. Good. Thank you. So uncontrolled asthma despite medium dose ICS LABA. So what is the next step? Okay. So this one is assuming that their technique is okay and they are adherent, right? So yeah. So this is our question number 9. So the following question be our last question, right? Green. Oh, someone said green. Add Lama green. Oh, add Lama. Oh, the green color is gone. Okay. All right. Add Lama and refer. Okay. Add Lama. So let's have a look. So thank you for answering on Facebook Live again. Oscar D, Meiji, use Rizal. You guys are really good. Good interaction on both sides. I have one eye here and one eye on the other side. Kugan as well. Thank you for answering. It's a rainbow, and that turtle features quite a lot, I must say.
Malaysian flag.
Oh, okay. All right. Good. Dr. Nida is excited about the Malaysian flag. The hibiscus, and someone's giving you some milk, I see. And the Malaysian flag comes again for the second time. Oh, yeah. I am rather hungry, you know. Oh, thank you.
Helicopter.
Okay, the ambulance is rather worrying. All of us are quite well in KKM, Parcel E1, and we like to remain so. Right?
Rocket.
The rocket, okay, yes. Oh, some medicine for us. Thank you. Oh, okay, all right. There's a ghost as well. Camera. Okay, that's good. Yes, we were taking pictures just now. So whoever sent the emoticon of camera is quite accurate. We also want to document this because we're very excited on this end. We feel very privileged to have spent this Saturday afternoon with you guys and to see such great interaction. Makes us feel happy that we've actually we don't think that we've given up the afternoon for nothing. I hope that, while we're doing all of this, that you also have learned quite a lot.
I think you can apply as a DJ.
Oh, okay.
Fireman.
Okay, noted. Okay, please do not send us that ZZ signs because so we have to drive back home and we do not have obstructive sleep apnea, right? Oh, Siti Chai says, add lama, green color lah. Okay, all right. Nice to know that we have the Malaysian slang even on Facebook. Add lama, refer. Okay. Yeah, so I do apologize for the little bit of traffic, right? And the coffee comes. Thank you. Yeah. Okay, let's have a look. Oh, well done. All right. Okay. So I think this is our last question, everyone. Yeah, oh yeah, there's a clap coming. Is it? I'm sure you are very happy this is the last question. So are we. So a 42-year-old man with asthma is on medium dose ICS LABA, right? Medium dose. He still has daily symptoms. And as mentioned, his technique and adherence good. So what's the next step, right? Medium dose ICS LABA, still symptomatic, right? So I think you just have to remember the algorithm, right? So I think so remember we say ICS is the backbone. So I think the stop ICS cannot be one of it, right? Here he is still symptomatic. If you stop the ICS, you are going to actually regress him back to even below step 1, and he's not going to improve. The inflammation that he has is just going to go on more and more, and he will actually probably present with a severe exacerbation. So I've taken away 1 from that. Okay. Okay. Oscar's answered. Coogan has answered. Meiji has answered. Oh, I see there's a flag. I'm not sure what it is. What flag is that?
Palestine.
Oh, Palestine. Okay, all right, good. Malaysia flag. All right. Sorry, I'm bad with flags. Oh, the ambulance. Okay, this ambulance really has to stop. No ambulance, please. All right. Oh, is that smoking cessation? Oh, well done. Smoking cessation, very important. It's a bit of fire, I see. Is that why the ambulance is here? It's a lot of fire.
SOS.
SOS, okay. All right. Green color, someone said. All right. Siti Chai, Meiji, Nadia. Well done. There's someone stuck out a tongue. That's not very polite, but it's okay. Ah.
Sabar sikit lagi. Sekejap je, time flies.
Yes, yeah. Yeah. Oh, there's a ring. Okay, someone sent us a ring. It's good. Oh, okay. Coogan, Chandran, thank you very much. You've left us a very nice comment. You said very insightful and comprehensive presentation today. Well done, Prof and team. Thank you very much. So thank you, Coogan, for your very nice words. We're very happy. Our drive back home will be like super fast and our heads are in the air. Thank you. Oh, the hearts come again. Okay, all right. I don't know. Yeah. Oh, okay. Oscar has said, thank you, Dr. Andrea and team. You guys are awesome. Oh, thank you very much, Oscar. And I see that you've been answering very well. Yeah, so Dr. Nida is very pleased that, her lecture is not for nothing. So thank you, Oscar. All right. And Siti Chai has now brought us back to baseline by saying how to add 4 points to my CPD. Okay, that one I cannot answer. I think I'll leave it to the MMA group to sort that out. Yeah. Okay, all right. So let's just see. Okay, the leaderboard. Okay. Okay, Nur Fatin said, thank you for the short course, short and sweet. You're very welcome. Okay, we end the session. Okay, all right. So congratulations to the winner, Eza. The second runner-up is 66749. And the third runner-up is, oh, the number disappeared. Okay, never mind. Don't worry. We have taken snapshots of it. Show names. Okay. So thank you very much, everyone.
Dia kena contact ni lah. And then
So can you contact for the Tuan Zamani? All right. So for the winners, the first winner, Eza, and the two with the numbers I can't remember. I don't have a photographic memory. Tuan Zamani, can you contact him? All right. So Siti Chai says, thank you to all presenters for your super presentation. Oh, so sweet. Thank you very much. Okay. And Rudy says, good job. Thank you very much. I think I would like to congratulate everyone who joined this session as well, right? And for those of you on Facebook Live, I also like to take this opportunity to thank the people in the background who have actually making sure that everything runs smoothly. It's not easy because we are quite a difficult bunch to control. Yeah. Okay. So hang on. Right. So we've done.
No. But he's like the Kuna organizer,
Oh, okay.
Tengku Farhana.
Yes. Okay. All right. So I've been asked, because they don't like my voice, I've got to pass the mic back to Tengku Farhana, who is actually the MC for today. Yeah. So Tengku Farhana, would you like to take over?
Thank you very much, Ambassador Associate Prof. Dr. Endra Van Yulin, and to all the
Thank you very much, Yang Berusaha Associate Professor Dr. Andrea Ban Yulin, and to all the speakers. That is very good interactive session, and congratulations to all the winners. Before we close the session, I would like to invite Yang Berusaha Dr. Tuan Zamani Amir to give his closing remarks on behalf of MMA and to conclude the session.
Hello. Assalamualaikum and thank you everyone. On behalf of PPS MMA, I would like to express our sincere appreciation to all our speakers for taking the time with us today, especially hari Sabtu on the weekend. Thank you again. Your commitment and willingness to share your expertise with all of us are truly valued. We are also very encouraged by the overwhelming response. We have full house, 500 plus people on Zoom, and many more joining via Facebook Live. I think the highest was 200 plus on Facebook Live, reflecting how strong interest in improving asthma care in primary practice. We hope today's session have been beneficial and practical for your daily clinical work. All participants will receive their CPD points manually. However, those who join via Facebook Live are required to complete their attendance link before 4:30 p.m. But remember, only participants who registered prior to the CME will be eligible to receive the CPD points and e-certs. Another thing is a post-event survey will be shared via email, and we greatly appreciate your feedback. Thank you again, and we look forward to seeing you in our upcoming seminars. Thank you.
Thank you very much, Dr. Tuan Zamani. Next, I would like to invite again Yang Berusaha, Dr. Karen Shamini, to share the information about a research study conducted by MATAS. Please welcome Dr. Karen Shamini.
Thank you, Kuna. Thank you, everybody, and congratulations for successfully completing your training on CPG management of asthma in adults. So I hope that these training, you would put it in your practice and there would be good improvements in your asthma management at primary care. So before we conclude, in 2 weeks, we will be sending you an email with a survey to check on the fidelity of the use of the CPG management in asthma in adults. You will have to fill up a short survey, whereby after completion, we will then give you your certs for this training. So I hope all of you would participate in this survey so that we could make the future sessions to be more interactive and to have some improvements in our coming webinars. So thank you once again, and congratulations again to all of you, and thank you to all our wonderful speakers, and lastly to MMA for providing us this opportunity. Thank you.
Okay, thank you very much, Dr. Sharon. With that, our training has come to an end. We would like to thank all participants who have Zoom and Facebook Live and also questions throughout the session. Before we leave, we hope that everyone will fill in the feedback form. The post survey will be emailed to you later after we receive the full attendance list from MMA, and we share the QR code for the feedback form now. So if you have any inquiries after this, please do not hesitate to contact us at cpgunit.cptk@moh.gov.my or MMA Secretariat. Thank you, and hopefully we'll see you again in the next session. Thank you very much.